Hi everyone, welcome to PharmaGrid. So today we are going to discuss about antimicrobial agents, starting with the principles of antimicrobial therapy. You all might be aware about the term antimicrobial resistance. So it is one of the top global public health and development threats. And what is the important reason behind this antimicrobial resistance? It is nothing but the misuse and overuse of antimicrobials in humans, animals and plants. These are the main drivers in the development of drug-resistant pathogen. And what is the consequence? This antimicrobial resistance puts many of the gains of modern medicine at risk. It makes infections harder to treat and makes other medical procedures and treatments such as surgery, cesarean sections, and cancer chemotherapy much riskier. So in this scenario, it's very important to understand the principles of antimicrobial therapy, which means how to choose an antibiotic appropriately and wisely. So that is what we are going to learn in this chapter. Antimicrobial drugs are effective in the treatment of infections because of their selective toxicity. So selective toxicity means these drugs have the ability to injure or kill an invading microorganism without harming the cells of the host. Then let's find out the difference between what is an antimicrobial drug and what is an antibiotic and what is an antibacterial drug. So antimicrobials means it is a wider term that includes all agents that act against microorganisms, namely bacteria, fungi, viruses and protozoa. Then antibacterials means these drugs act only on bacteria. This term broadly defines all compounds that act against bacteria, including antibiotics. Then antibiotics are produced naturally by microorganisms and kill or inhibit the growth of other microorganisms, mainly bacteria. So this is the difference between these terms. Now we will see about the selection of antimicrobial agents. So what are the factors that should be considered in order to select the most appropriate antimicrobial agent? So first and foremost one is the identification of the organism. So we need to identify the organism appropriately, then only we can choose the appropriate antibiotic. Then the second one is the susceptibility of the organism to a particular agent. You all might have heard about this culture and sensitivity test. So here we are mainly assessing whether the particular organism or particular microorganism is sensitive or resistant to a particular antibiotic. So that we are assessing here. So based on that only we need to choose an appropriate antibiotic. Then the site of infection. Okay, whether the infection has occurred. Is it a localized infection or a generalized equation? So it's a what kind of infection and where is the actual site? Okay, all these plays an important role in the selection of an appropriate antibiotic. Then the patient factors. Patient factors can be patient's age, then immune status, then any kind of organ dysfunction such as in case of any renal impairment, then hepatic impairment. So in such cases, we need to choose only antibiotics that fits to that particular condition of that particular patient. Now the safety and efficacy of the agent. Safety of the efficacy in such cases we need to consider the drug specific toxicities, then if there is any kind of contraindications. So all these factors should be considered. Then the cost of therapy. Cost of therapy also has an important role in choosing an appropriate antibiotic. So all these factors are really important in the selection of antimicrobial agents. So again, in this slide, I have pointed out the factors which influence the antibiotic choice. Mainly the disease factors, host factors. Host factors, nothing but the patient-related factors. Then organism factors and the drug-related factors. So under disease factors mainly includes the travel history, then occupation, recreational exposure, IVDU. IVDU means intravenous drug use. Then severity of the illness, urgency of therapy, reliability of the cultures. Then patient-related factors mainly includes the age, then clearance organ function, if there is any kind of allergies, then immune status, HIV, pregnancy and lactation. Then organism related factors includes the source control, susceptibility, empiric versus specific. Empiric means which has got a broad range of activity and specific means only targeted or can only affect that particular microorganism. So regarding this we will discuss in the coming slides. Then intra versus extracellular, then duration of the therapy, assessment of the response. So all these are organism related factors. Then drug related factors includes the cost, toxicity, bioavailability. Bioavailability is nothing but the rate and extent of drug absorption, source site penetration, drug synergy, bacteriostatic versus bactericidal. So we will see the first factor in detail, which is the identification of the infecting microorganism. So in order to identify the microorganisms, a lot of laboratory tests are available, such as gram stain, microbiological culturing, and susceptibility test. So these tests should be performed before anti-infective therapy is initiated. So gram stain is useful in identifying the presence and morphologic features of microorganisms in body fluids that are normally sterile, such as blood, cerebrospinal fluid, pleural fluid, synovial fluid, peritoneal fluid, and urine. It is essential to obtain a sample culture of the organism prior to initiating the first dose of antibiotic. So this is a very important point. So in order to start the first dose, before starting the first dose of antibiotic, it is very mandatory to obtain a sample culture of the organism. Definitive identification of the infecting organism may require other laboratory techniques such as detection of microbial antigens, DNA or RNA, or an inflammatory or host immune response to the microorganism. Newer techniques such as PCR, that is rapid polymerase chain reaction, then and matrix assisted laser desorption or ionization time of flight mass spectrometry offer accurate, rapid, and cost effective identification of the infecting organism. So as I have already mentioned in the previous slide, so before starting the first dose of an antibiotic or an antimicrobial drug, it is very important to obtain the culture or sample of that particular organism. So there is an exception to this case, and this is nothing but the empiric antimicrobial therapy. That is, in serious or life-threatening disease conditions, anti-infective therapy must begin before the infecting organism has been identified. So in this case, the choice of drug is based on clinical experience, suggesting that a particular agent is effective in a given setting. So in this case, in case of empirical antimicrobial therapy, a broad spectrum antibiotic usually is the most appropriate choice until the specific organism has been determined. Okay, so these antibiotics used for empirical therapy are usually broad spectrum antibiotics and should be substituted with narrow spectrum antibiotics within 48 to 72 hours as per culture and sensitivity report. Now regarding the timing. Acutely ill patients with infections of unknown origin, for example, a neutropenic patient or a patient with meningitis, require immediate treatment. If possible, therapy should be initiated after specimens for laboratory analysis have been obtained, but before the results of the culture and sensitivity are available. Now, selecting a drug. It should be based on certain factors such as the site of infection, the patient history, for example, previous infections, age of the patient, recent travel history, recent antimicrobial therapy, immune status, whether the infection was hospital or community acquired, and local susceptibility data. Then broad spectrum therapy. Broad spectrum antibiotics means those antibiotics or antimicrobials that covers a wide range of microorganisms. So this broad spectrum therapy such as third or fourth generation cephalosporins, doxycycline and fluoroquinolones may be indicated initially when the organism is unknown or polymicrobial infections are likely. That means in case of empirical therapy in the sense if a patient has life-threatening conditions, in such cases we cannot wait until the organism could get identified. So in such cases we need to start empirical antimicrobial therapy usually with broad spectrum antibiotics. Broad spectrum antibiotics means those that covers a wide range of microorganisms. Then selection of drug may also be guided by non-association of particular organisms in a given clinical setting. So this could be understood with the help of an example. For example, gram-positive cocci in the spinal fluid of a newborn is unlikely to be Streptococcus pneumonia and most likely to be Streptococcus agalactiae, which is a group B streptococci which is sensitive to penicillin G. Okay. By contrast, gram-positive cocci in the spinal fluid of a 40-year-old patient are most likely to be Streptococcus pneumoniae. This organism is frequently resistant to penicillin G and often requires treatment with a high-dose third-generation cephalosporin such as ceftriaxone or vancomycin. So in this example, we are taking the case of a newborn as well as an adult patient, a 40-year-old patient. So in a newborn, gram-positive cocci in the spinal fluid of a newborn, the most likely causative organism will be Streptococcus agalactiae. Okay, Streptococcus agalactiae, which is sensitive to penicillin G. Okay, but in the same case, that is a gram-positive cocci in the spinal fluid, if it is in a 40-year-old patient, the causative organism is not same. Here the causative organism or most likely the etiology will be Streptococcus pneumoniae. The Streptococcus pneumoniae, this organism is frequently resistant to penicillin G. In this case, we cannot use penicillin G. Okay, so in this case, the particular patient requires treatment with a high dose third generation cephalosporin such as ceftriaxone or vancomycin. Okay, so this is the difference. Now, the determination of antimicrobial susceptibility. The minimum inhibitory and bactericidal concentrations are used in determining susceptibility of a drug and can be experimentally determined. So, in order to determine the antimicrobial susceptibility, we are taking into consideration the minimum inhibitory and bactericidal concentrations. So, what do you mean by bacteriostatic and bactericidal drugs? Bacteriostatic. Okay, static means or bacteriostatic means the agent that prevents the growth of bacteria. Okay, static means it only prevents the growth. That is, it keeps them in the stationary phase of growth. Whereas bactericidal, okay, cidal means killing. So bactericidal means that it kills the bacteria. Okay, so bacteriostatic means it prevents the growth of bacteria, whereas bactericidal means it kills the bacteria. Examples for bacteriostatic drugs include chloramphenicol, erythromycin, clindamycin, sulfonamides and tetracyclines. Bactericidal drugs include aminoglycosides, beta-lactam antibiotics, vancomycin, quinolones, rifampicin and metronidazole. It is also possible for an antibiotic to be bacteriostatic for one organism and bactericidal for another. For example, linezolid. Linezolid is an antibiotic. It is bacteriostatic against Staphylococcus aureus and Enterococci, but it is bactericidal against most strains of Streptococcus pneumonia. Some antimicrobials can be both bacteriostatic and bactericidal depending on dose, duration of exposure, concentration and state of the invading bacteria. Next, one important point is concentration dependent killing. That is, the rate and extent of killing of microbes increases with increasing drug concentration. Okay, so from the word itself, it's clear that is concentration dependent killing. That is, if we increase the concentration of the antibiotics, that will lead to maximum killing of the microbes. Okay, that means such antibiotics are concentration dependent. For example, aminoglycosides, fluoroquinolones and metronidazole. Next, one important term associated with this regarding these principles of antimicrobial therapy is minimum inhibitory concentration or MIC. So what is this MIC? It is the lowest antimicrobial concentration that prevents visible growth of an organism, that is microorganism, after 24 hours of incubation. Minimum. Okay, so from the word itself, minimum means lowest. It is the lowest antimicrobial concentration that prevents, okay, that prevents the visible growth of an organism after 24 hours of incubation. A lower MIC indicates that the antibiotic is more effective. Okay, so that means lower concentration is required. For an antibiotic to be effective, lower concentration is required. Okay, that which is meant by this statement, that is a lower MIC, that is a lower minimum inhibitory concentration indicates that the antibiotic is more effective. Then this MIC is a quantitative measure of in vitro susceptibility and it is commonly used in practice to streamline therapy. Computer automation has improved the accuracy and decreased the turnaround time for determining MIC results and it is the most common approach used by clinical laboratories. So we have seen about MIC, which is the minimum inhibitory concentration. It is the lowest concentration of an antimicrobial agent that is bacteriostatic. That means prevents the visible growth of bacteria. Now we will see about MBC, that is minimum bactericidal concentration. So it is also the lowest concentration of an antibacterial agent required to kill a bacterium over a fixed somewhat extended period such as 18 hours or 24 hours under a specific set of conditions. So this is the difference. So MBC is the lowest concentration of antimicrobial agent that results in a 99.9% decline in colony count after overnight broth dilution incubations. The MPC is rarely determined in clinical practice due to the time and labor requirements. Now, time dependent killing. So in the previous slide, we have seen about concentration dependent killing. That is, if we increase the concentration of certain antibiotics, that will increase the or that will lead to maximum killing of the microbes. So time dependent killing, that is bactericidal activity, continues as long as the serum concentration is maintained above the minimum inhibitory concentration for the entire interval between doses. For example, beta-lactam and vancomycin. So these type of antibiotics, okay, in case of antibiotics such as beta-lactam antibiotics and vancomycin, they mainly kill the microbes based on time. Okay, time means So how long the serum concentration of these antibiotics is maintained above the minimum inhibitory concentration that will result in maximum killing of the antibiotics. This is known as time dependent killing. Examples include beta-lactam antibiotics and vancomycin. Now moving on to the next factor, which is the site of infection. So what is the effect of site of infection on the therapy? Then first let's see about the blood-brain barrier. We know that our body has got certain natural barriers. So natural barriers to drug delivery are created by the structures of the capillaries of some tissues such as the prostate, testes, placenta, the vitreous body of the eye and the central nervous system. The penetration and concentration of an antibacterial agent in the cerebrospinal fluid are particularly influenced by the following. First one is the lipid solubility. We know that the blood-brain barrier is made up of lipids, okay, lipid membrane. So a drug that is highly lipid soluble can easily penetrate the blood-brain barrier. So this lipid solubility is a major determinant to penetrate the blood-brain barrier. Lipid soluble drugs such as chloramphenicol and metronidazole have significant penetration into the CNS, whereas beta-lactam antibiotics such as penicillin are ionized at physiologic pH and have low lipid solubility. Therefore, they have limited penetration through the intact blood-brain barrier under normal circumstances. Then, some beta-lactam antibiotics can enter the cerebrospinal fluid in therapeutic amounts when the meninges are inflamed. For example, in case of meningitis. In meningitis, what will happen? The brain becomes inflamed. The barrier, that is a blood-brain barrier, cannot function properly. The barrier does not function as effectively and local permeability is increased. In such cases, some beta-lactam antibiotics can enter the cerebrospinal fluid. And the next factor is molecular weight. Okay, molecular weight. So under this blood-brain barrier, we are discussing some more factors. So under the blood-brain barrier, we have seen the lipid solubility. Highly lipid soluble drugs can easily cross the blood-brain barrier and can penetrate the CNS very fastly. And the second one is the molecular weight. Low molecular weight that will enhance the ability to cross the blood-brain barrier. And high molecular weight drugs, for example vancomycin, penetrate poorly even in the presence of meningeal inflammation. So this is about the molecular weight. So low molecular weight drugs can easily cross the blood-brain barrier compared to high molecular weight drugs. Next one is the protein binding. Protein binding. So we have already seen what is absorption, distribution, metabolism and elimination in the pharmacokinetics chapter. So protein binding, a high degree of protein binding of a drug restricts its entry into the cerebrospinal fluid. So this is the case if a drug we have absorbed or we have taken one drug, if that particular drug is highly bound to the plasma protein. Okay, if it is highly bound, so there is some restriction to entry into the cerebrospinal fluid. It cannot be easily detached from the protein and get entry into the cerebrospinal fluid. So this is the case. So if a drug or if a particular antimicrobial drug has got high protein binding, such drugs will have restricted entry or permits slow entry into the cerebrospinal fluid. And the next one is susceptibility to transporters or efflux pumps. Antibiotics that have an affinity for transporter mechanisms or do not have an affinity for efflux pumps have better CNS penetration. Now we will see about patient factors involved in the selection of an appropriate antibiotic. So under this, the first point is immune system, alcoholism, diabetes, HIV infection, malnutrition, autoimmune diseases, pregnancy, advanced age and immunosuppressive drugs can affect immunocompetence. Then the next point is renal dysfunction. We know that the major excretory organ in our body is kidney. So poor kidney function may cause accumulation of certain antibiotics. So in such cases, dosage adjustment is required. Dosage adjustment prevents drug accumulation and adverse effects. So in order to do the dosage adjustment, we are mainly using the serum creatinine levels. Okay, serum creatinine levels is an index of renal function for adjustment of drug dosage regimens. Direct monitoring of serum levels of some antibiotics, for example vancomycin and aminoglycosides, is preferred to identify maximum and or minimum values and prevent potential toxicities. Then elderly patients are particularly vulnerable to accumulation of drugs eliminated by the kidneys even with normal serum creatinine levels. Next one is the hepatic dysfunction. We know that the metabolism in our body takes place in the liver. So antibiotics that are concentrated or eliminated by the liver, for example erythromycin and doxycycline, must be used with caution when treating patients with liver dysfunction. Then poor perfusion. Poor perfusion means nothing but reduced blood flow. So decreased circulation to an anatomic area such as the lower limbs of a diabetic patient reduces the amount of antibiotic reaching the site of infection. Okay, so this will make it treatment more complicated or treatment more difficult. Then decreased perfusion of the gastrointestinal tract may result in reduced absorption, making attainment of therapeutic concentrations more difficult with enteral routes. And the next one is age, which is also an important patient-related factor. Renal or hepatic elimination processes are often poorly developed in newborns. Okay, this is the reason why the newborns are highly vulnerable to the toxic effects of agents such as chloramphenicol and sulfonamides. Chloramphenicol can cause gray baby syndrome in newborns. Then young children should not be treated with the tetracyclines or quinolones, which affect bone growth and joints respectively. Then elderly patients may have decreased renal or liver function. That is, as the age progresses, the organ functions will decline. So because of this, it may alter the pharmacokinetics of certain antibiotics. And the next point is pregnancy and lactation. So many antibiotics cross the placental barrier or enter the nursing infant via the breast milk. So prescribers should consult the product labeling of an antibiotic to review the risk summary and clinical considerations for use in pregnancy and lactation. So in one of my previous video, I have already discussed about the pregnancy categories. That is the category A, B, C, D and X, which is the safest one and which one is absolutely contraindicated. So only very few drugs are safe in case of pregnancy. So the drug should be choose accordingly. Although the concentration of an antibiotic in fetal circulation or in breast milk is usually low, the total dose to the infant may be sufficient to produce detrimental effects. For example, congenital abnormalities have been reported after administration of tetracyclines to pregnant women, and these agents should generally be avoided in pregnancy due to the risks to the fetus. Risk factors for multi-drug resistant organisms. So infections with multi-drug resistant pathogens need broader antibiotic coverage when initiating empiric therapy. So the common risk factors include prior antimicrobial therapy in the preceding 90 days. Then hospitalization for greater than 2 days within the preceding 90 days. Then the next risk factor is current hospitalization exceeding 5 days. Then high frequency of resistance in the community or local hospital unit, assessed using the hospital antibiograms. Then immunosuppressive diseases and or immunosuppressive therapies. So all these are risk factors for the emergence of multi-drug resistant organisms. So the next factor affecting the selection of an appropriate antibiotic is the safety of the agent. Penicillins are among the least toxic of all antimicrobial drugs because they interfere with a site or function unique to the growth of microorganisms. Other antimicrobial agents, for example chloramphenicol, which is a broad spectrum antibiotic, have less specificity and are reserved for life-threatening infections because of the potential for serious toxicity to the patient. So safety is related not only to the inherent nature of the drug but also to the patient factors. Next one is the cost of therapy. Although the choice of therapy usually centers on the site of infection, severity of the illness, and ability to take oral medications, it is also important to consider cost of the medication. Moving on to the routes of administration. We know that different routes of administration are available such as oral, then parenteral, inhalational, transdermal, rectal, likewise. So oral route is usually appropriate for mild infections that can be treated on an outpatient basis. Then parenteral administration. Under parenteral route comes the intravenous, intramuscular, subcutaneous, likewise. So this parenteral administration is usually preferred for drugs that are poorly absorbed from the gastrointestinal tract and patients with serious infections who require maintenance of higher serum concentrations of antimicrobial agents. Then once the patient becomes clinically stable, this IV therapy or the parenteral therapy should be switched to the oral therapy. So switching patients from intravenous to oral therapy when clinically stable has been shown to decrease healthcare costs, shorten length of stay and decrease complications from intravenous catheters. However, some antibiotics such as vancomycin and aminoglycosides are poorly absorbed from the gastrointestinal tract and do not achieve adequate serum levels via the oral administration. Determinants of rational dosing. That is, the rational dosing of antimicrobial agents is based on the pharmacokinetic and pharmacodynamic properties of the drug. Pharmacokinetic properties or the pharmacokinetic parameters mainly includes the four parameters, that is the ADME parameters: absorption, distribution, metabolism and elimination of the drug. And pharmacodynamics, it's nothing but the relationship of drug concentrations to antimicrobial effects. So the three main determinants of rational dosing of antimicrobial agents includes the concentration dependent killing, time dependent killing. Time dependent killing is also known as concentration independent killing, and the last one is the post antibiotic effect. So the first one is concentration dependent killing. We have already seen this before. So here the killing of microbes depends upon the concentration of the antibiotic. So if we increase the concentration of the antibiotic, there will be maximum killing of the microbes. That is, the rate and extent of killing increases as the peak drug concentration increases. So the drugs that perform or drugs that exhibit concentration dependent killing, the major examples include aminoglycosides and fluoroquinolones. So this concentration dependent killing is a property associated with the drugs inhibiting protein or DNA synthesis. The largest mainly for this aminoglycosides and fluoroquinolones. And one more important point, these drugs also exhibit a post antibiotic effect. Post means after. Okay, after antibiotic effect. That means it is nothing but the persistent suppression of the bacterial growth even after the bacterial concentration or even after the antibiotic concentration has fallen below the MIC. That is, it is a persistent suppression of bacterial growth after limited exposure to an antibiotic. Then proposed mechanisms include slow recovery of bacteria after non-lethal damage to cell structures, then persistence of the antibiotic at its binding site. For example, aminoglycosides bind irreversibly to ribosomes, then a need for bacteria to synthesize new proteins before growth can continue. Now, what is the clinical significance of concentration dependent killing or this post antibiotic effect? So, antibiotics which exhibit this long post antibiotic effect can be administered at longer dosing intervals than would be predicted by their pharmacokinetic profile. Dosing intervals means it is the interval or gap between the two doses. So, antibiotics which exhibit long post antibiotic effect can be administered at longer dosing intervals. So longer dosing intervals means fewer tablets per day. Okay, so this can reduce the blood levels and side effects yet maintain the clinical efficacy. Then fewer doses per day tends to increase the adherence or patient compliance to the therapy. An example for this is the characteristic feature of aminoglycoside. That is, this characteristic is responsible for the efficacy of once daily dosing of aminoglycosides. So aminoglycosides, they have got longer dosing interval. Mainly they are given as once daily dosing because of its long post antibiotic effect. And the next one is time dependent or concentration independent killing. So here the clinical efficacy of these antimicrobials is best predicted by the percentage of time that blood concentrations of a drug remain above the MIC. So time dependent. Here the killing of microbes depends upon the time that the blood concentration of a drug remain above the minimum inhibitory concentration. So bactericidal activity continues as long as the plasma concentration is greater than the minimum bactericidal concentration or minimum inhibitory concentration. So do not exhibit concentration dependent killing. Okay, it exhibits concentration independent killing. So examples include beta-lactam antibiotics, glycopeptides, macrolides, clindamycin and linezolid. So here in case of time dependent killing, in order to maintain the drug concentration above the minimum inhibitory concentration, the drug should be given at frequent time intervals. For example, dosing schedules for penicillins and cephalosporins. Penicillins and cephalosporins are beta-lactam antibiotics. So in case of penicillins and cephalosporins that ensure blood levels greater than the MIC for 50% and 60% of the time respectively provide the most clinical efficacy. Therefore, extended means generally 3 to 4 hours or continuous. Continuous infusion means 24-hour infusion can be utilized instead of intermittent dosing, that is generally 30 minutes, to achieve prolonged time above the MIC and kill more bacteria. Other drugs such as fluoroquinolones and vancomycin work best by optimizing the ratio of the 24-hour area under the concentration time curve to MIC. The AUC24 is the overall exposure of a drug during the dosing interval and takes into account the concentration as well as the time. Now, what is the clinical significance of this time-dependent killing? Here, the free concentration of these drugs should be maintained above the minimum inhibitory concentration for a drug-specific fraction of time. For example, greater than 30% or greater than 50% in between repetitive doses in order to achieve a favorable clinical outcome. So here you can see a graphical representation which will be helpful to easily differentiate between time-dependent killing and concentration-dependent killing. So let's take the first example, which is time-dependent antibiotics or time-dependent killing, which is shown by drugs such as beta-lactam antibiotics. So here you can see concentration versus time is plotted, and here a line is drawn which is the MIC, that is the minimum inhibitory concentration. So in time dependent killing, what is happening here? The drug concentration should be maintained. Okay, the time So higher the time the drug concentration is above the MIC, higher will be the killing of microbes. Okay, so this is the MIC, that is the time. Time should be more. Okay, more time, the drug concentration should be above the minimum inhibitory concentration, that will result in maximum killing of the microbes. Now let's see about the concentration dependent antibiotic. For example, aminoglycosides. Okay, so this is the concentration. Okay, higher the concentration. Okay, here Cmax. Cmax is the maximum concentration. So higher the concentration, there will be maximum killing of microbes. Again, this is the same graphical representation only. Concentration, that is the drug concentration versus time curve. So here you can see the MIC, which is the minimum inhibitory concentration, and this is the Cmax. So examples for concentration dependent killing or concentration dependent antibiotics include aminoglycosides, daptomycin. Then time dependent antibiotics include beta-lactam antibiotics, clindamycin. Then time and concentration dependent antibiotics. Examples include vancomycin, fluoroquinolones, linezolid, and tetracycline. And the next determinant is post-antibiotic effect. We have already seen this. It is nothing but the persistent suppression of microbial growth that occurs after levels of antibiotic have fallen below the minimum inhibitory concentration. That means certain antibiotics such as aminoglycosides and fluoroquinolones can kill the microbes even after their concentration or even after their drug levels has fallen below the minimum inhibitory concentration. So this is known as the post-antibiotic effect. Antimicrobial drugs exhibiting a long post-antibiotic effect. For example, aminoglycosides and fluoroquinolones often require only one dose per day, particularly against gram-negative bacteria. Strong post-antibiotic effect is mainly seen in drugs which have concentration-dependent kill characteristics. We have already discussed in the previous slides. Then one more drug which has got probably the longest post-antibiotic effect is quinupristin bar dalfopristin. Moving on to the chemotherapeutic spectra. Based on their spectrum of activity, and antibiotics can be classified into three. Okay, that is narrow spectrum, extended spectrum, and a broad spectrum antibiotics. So narrow spectrum. So from the word itself, narrow. Narrow means acting only on a single or a limited group of microorganisms. For example, isoniazid. Isoniazid is an anti-tubercular drug. It is active only against Mycobacterium tuberculosis. So hence it is a narrow spectrum antibiotic. Next one is extended spectrum antibiotics, which means they are effective against gram-positive organisms and also against a significant number of gram-negative bacteria. For example, ampicillin. Ampicillin is an extended spectrum penicillin. It is considered to have an extended spectrum because it acts against gram-positive and some gram-negative bacteria. Then the third one is broad spectrum antibiotics. Broad. Okay, so from the word itself, it affects a wide variety of microbial species. Such as chlamydia, then other protozoa likewise. For example, fluoroquinolones and carbapenems can drastically alter the nature of the normal bacterial flora and precipitate a superinfection due to organisms such as Clostridium difficile, the growth of which is normally kept in check by the presence of other colonizing microorganisms. Okay, so here you can see these are the medically important microorganisms. That is gram-positive cocci and bacilli, gram-negative cocci and bacilli, then anaerobic organisms, spirochetes, mycoplasma, chlamydia and others. So let's first see this isoniazid. It is a narrow spectrum antimicrobial drug. Why? Because it is effective only against Mycobacterium tuberculosis. It is ineffective against other microorganisms. Then next one is ampicillin, which is an extended spectrum antimicrobial drug. So it has got activity against gram-positive cocci and gram-positive bacilli and some gram-negative rods such as E. coli, Haemophilus influenza, Proteus mirabilis, etc. Hence, it is known as extended spectrum antimicrobial drug. Then the third one is tetracycline, which is a broad spectrum antimicrobial drug. It has got activity against a wide range of microorganisms such as gram-positive organisms, gram-negative organisms, then anaerobic organisms, spirochetes, mycoplasma, chlamydia, and others such as actinomyces, rickettsia, and amoeba. So this is how the difference came. So isoniazid is a narrow spectrum antibiotic, ampicillin is an extended spectrum, tetracycline is a broad spectrum antimicrobial drug which covers a wide variety of microorganisms. Now, the combinations of antimicrobial drugs. Sometimes you might have seen that some antibiotics are given in combination. So what is the advantage and disadvantages of this antibiotic combinations? So combinations of these antimicrobial drugs reduces the possibility of superinfections, decreases the emergence of resistant organisms and minimizes toxicity. Now let's discuss in detail about the advantages of drug combinations. First example is beta-lactams and aminoglycosides. They show synergism. Synergism means the combination is more effective than either of the drugs used separately. For example, cotrimoxazole. Okay, cotrimoxazole is a trimethoprim sulfamethoxazole combination, then amoxicillin and clavulanic acid. Okay, so these combinations show synergism. Okay, synergism. That is, this combination is more effective than either of the drugs are given separately. Then synergistic combinations are only indicated in special situations, for example in the treatment of enterococcal endocarditis, etc. Then combinations may be used as empirical treatment until a more specific diagnosis has been made or ineffective organism has been isolated when an infection is of unknown origin or when there are organisms with variable sensitivity, such as when treating tuberculosis, leprosy and HIV or AIDS to prevent development of resistance. So mainly the advantage of this combination of antimicrobial drugs is to reduce the possibility of superinfections, decrease the emergence of resistant organisms and also to minimize the toxicity. Now, what are the disadvantages of these drug combinations? So, co-administration of an agent that causes bacteriostasis plus a second agent that is bactericidal may result in the first drug interfering with the action of the second drug. For example, bacteriostatic tetracycline drugs may interfere with the bactericidal effects of penicillins and cephalosporins. Then risk of selection pressure and the development of antibiotic resistance by giving unnecessary combination therapy. Then use of irrational fixed dose combinations of antibiotics or less evidence to combinations should be discouraged. Some of the irrational combinations are amoxicillin tazobactam, ofloxacin bar ornidazole or tinidazole, then gartifloxacin ornidazole, then fluconazole tinidazole combinations are some irrational combinations. So such combinations should be avoided. Drug resistance. So bacteria are considered resistant to an antibiotic if the maximal level of that antibiotic that can be tolerated by the host does not halt bacterial growth or does not suppress bacterial growth. Some organisms are inherently resistant to an antibiotic. For example, most gram-negative organisms are inherently resistant to vancomycin. However, microbial species that are normally responsive to a particular drug may develop more virulent or resistant strains through spontaneous mutation or acquired resistance and selection. Some of these strains may even become resistant to more than one antibiotic. Now, what are the reasons for this drug resistance? Drug resistance, the main reason is inappropriate use of antibiotics, and what is the mechanism behind this drug resistance? So, genetic alterations leading to drug resistance, temporary or permanent gain or alteration of bacterial genetic information. Resistance develops due to the ability of DNA to undergo spontaneous mutation or to move from one organism to another. Next mechanism is through the altered expression of proteins in drug-resistant organisms. So under this, through the modification of target sites. Alteration of the target site of an antibiotic through mutation can confer resistance to one or more related antibiotics. For example, Streptococcus pneumoniae resistant to beta-lactam antibiotics involves alterations in one or more of the major bacterial penicillin binding proteins, resulting in decreased binding of the antibiotic to its target. Next mechanism is by decreased accumulation. Decreased uptake or increased efflux of an antibiotic can confer resistance because the drug is unable to attain access to the site of its action in sufficient concentration to injure or kill the organism. For example, gram-negative organisms can limit the penetration of certain agents, including beta-lactam antibiotics, as a result of an alteration in the number and structure of porins. Porins means nothing but the channels in the outer membrane. Also, the presence of an efflux pump. Efflux means that will let the antibiotic to go out. So also the presence of an efflux pump can limit the levels of a drug in an organism as seen with tetracyclines. Next one is through enzyme inactivation. Certain enzymes have the ability to destroy or inactivate the antimicrobial agent. So examples of such antibiotic inactivating enzymes include beta-lactamases. So beta-lactamases are also known as penicillinases that hydrolytically inactivate the beta-lactam ring of penicillins, cephalosporins and related drugs. Second one is acetyl transferases. These enzymes transfer an acetyl group to the antibiotic, inactivating chloramphenicol or aminoglycosides. Then esterases. Esterases will hydrolyze the lactone ring of macrolides. So these are some important antibiotic inactivating enzymes. So in this slide you can see the mechanisms of resistance to antibiotics. It is summarized here. mainly the drug resistance due to altered targets, then drug resistance due to decreased accumulation, either due to decreased permeability or due to increased efflux, then drug resistance due to enzymatic inactivation. So you can refer this slide for further clarification. Now the factors leading to increase in antimicrobial resistance, which is one of the global problem. So antimicrobial resistance is one of the world's most serious public health problems, resulting in prolonged illness and hospitalization. Development and spread of antimicrobial resistance is due to the following reasons. So the first and foremost one is overuse, misuse and irrational use by the doctors. Then non-compliance to the prescribed regimen, self-medication and use of leftover antibiotics by the patient. So if a doctor, suppose if a doctor has prescribed an antibiotic for a duration of 5 days, okay, so the particular patient should take that particular drug for the prescribed days, okay. So if that patient do not take the medicine accordingly, that can lead to antimicrobial resistance, okay. So that is how the non-compliance to medications can lead to antimicrobial resistance. Then use of antibiotics in animal husbandry, aquaculture and agriculture. Then poor infection control in the healthcare settings, then poor hygiene and sanitation, then absence of new antibiotics being discovered. So these all are the factors that leading to the increase in the antimicrobial resistance. Other factors that promote antibiotic resistance in community and hospital settings are antibiotic selective pressure, then prolonged antibiotic treatment, inadequate doses, then prior use of a less effective drug of the same antibiotic class, protected sites or foreign bodies. Now moving on to the prophylactic use of antibiotics. So prophylaxis means it's a preventive measure. Okay, so it means the use of antibiotics for the prevention rather than for the treatment of infection. Usually, a single dose of an antibiotic 60 minutes before incision is required. The choice of an antibiotic and duration of therapy depends upon the type of surgery. So prophylactic use is restricted to clinical situations in which the benefits outweigh the potential risks. The duration of prophylaxis should be closely controlled to prevent the unnecessary development of antibiotic resistance. Where prophylaxis is to be continued for longer than 24 hours, it should be clearly documented along with the reasons in the clinical case notes. So here you can see the clinical situations in which prophylactic antibiotics are indicated. So first one, pre-treatment may prevent streptococcal infections in patients with a history of rheumatic heart disease. Patients may require years of treatment. Then pre-treating of patients undergoing dental extractions who have implanted prosthetic devices such as artificial heart valves prevents the seeding of the prosthesis. Then pre-treatment may prevent tuberculosis or meningitis among individuals who are in close contact with infected patients. Then treatment prior to most surgical procedures can decrease the incidence of infection afterwards. Effective prophylaxis is directed against the most likely organism, not eradication of every potential pathogen. So these are the situations in which prophylactic antibiotics are indicated. Moving on to the complications of antibiotic therapy. So the first one is hypersensitivity or immune reactions to antimicrobial drugs or their metabolic products frequently occur. One major example is penicillins. Okay, penicillins can cause serious hypersensitivity problems ranging from urticaria to anaphylactic shock. Then Redman syndrome associated with a rapid infusion of vancomycin. Then patients with a documented history of Stevens-Johnson syndrome or toxic epidermal necrolysis reaction, which is mainly a severe sloughing of skin and mucous membrane. So in those patients which have got a documented history of these conditions, to an antibiotic should never be rechallenged. Rechallenge means such antibiotics should not be given again to that particular patients, not even for antibiotic desensitization. Direct toxicity, that is certain antibiotics can cause direct toxicity. For example, aminoglycosides can cause ototoxicity by interfering with membrane function in the auditory hair cells. Then chloramphenicol can have a direct toxic effect on mitochondria, leading to bone marrow suppression. Fluoroquinolones can have effects on cartilage and bones, and tetracyclines have direct effect on the bones. A number of antibiotics can cause photosensitivity. So the next complication is superinfections. Drug therapy, particularly with broad spectrum antimicrobials or combination of agents, can lead to alterations of the normal microbial flora of the upper respiratory, oral, intestinal and genitourinary tracts. So this will permit the overgrowth of opportunistic organisms, especially fungi or resistant bacteria. These superinfections usually require secondary treatments using specific anti-infective agents. Then Jarisch-Hexheimer reaction. It is the development of exacerbations of skin lesions in patients undergoing treatment for syphilis with mercurial compounds, then reported in patients undergoing treatment with antimicrobials for spirochetal infections such as syphilis, Lyme disease, leptospirosis, and relapsing fever, manifested by fever, chills, headache, myalgia, and exacerbation of skin rashes within 24 hours of antimicrobial treatment. These symptoms are expected to resolve a few hours later. Antimicrobials such as penicillins, tetracyclines, erythromycin, cephalosporins meropenem, then ciprofloxacin, levofloxacin, clarithromycin, and azithromycin are also reported to provoke the Jarisch-Hexamer reaction. Here you can see the sites of antimicrobial action. So mainly the cell wall synthesis inhibitors such as beta-lactam antibiotics such as penicillin, cephalosporin, they are cell wall synthesis inhibitors. Then protein synthesis inhibitors. Then DNA gyrase inhibitors likewise. Okay, so these all are the major sites of antimicrobial actions. So we will discuss each class of antibiotics in detail in the upcoming videos. So now let's see some common errors while prescribing antibiotics. So antibiotics given before cultures are taken, then poor quality blood culture collection, then ridiculously long courses of antibiotics, then widely erratic changes of antibiotics such as antibiotic surfing when the sepsis is not improving, then inadequate doses, poor choice of empirical antibiotics, failing to account for resident flora, then failure to predict toxicity or account for interactions, inappropriate use of antibiotic polypharmacy. So we have completed the principles of antimicrobial therapy. Hope you all have liked this video. Thank you everyone for watching this video. Please like, share and support. So have a good day.